So once we have fluid reabsorbed in at the venous end of the capillaries, how do we get it back to the heart? This is the concept of venous return. The first and most important way is that blood pressure is going to push blood back towards the heart. In the venules, we have about 12 to 18 millimeters of mercury for pressure. And the central venous pressure, where the vena cava enter the heart, is just about 5 millimeters of mercury. So there's a 7 to 13 millimeter of mercury pressure difference going towards the heart. Gravity is important in draining blood back from the head and neck. The venous pressure in the large veins of the neck is close to zero because gravity takes care of most of it. There's also a skeletal muscle pump. That is, the action of our limbs is going to pump blood back towards the heart. As the muscles contract, they squeeze blood out of the vessels and compress every part of the vein. We can see an example of the skeletal muscle pump here, where in the relaxed skeletal muscle, there's a little bit of venous blood pooling behind the valves. However, when this muscle contracts, it squeezes the blood out of the vessels, and it can only move one way because of the valves, so it goes up through the valve and then is trapped on the other side of the valve and can't return when the muscle releases. So then in this fashion, the muscles do a lot to pump blood back to the heart. And you notice this if you sit on an airplane and don't move for an extended period of time, you'll see that the blood pools in the vessels in your feet. However, if you get up and walk around and use the action of your skeletal muscles, the blood will once again leave your feet and return to the heart. This is an interesting experiment. You can do this on yourself. If you block a vessel at the proximal end and then squeeze blood back towards the heart, past the next valve, then no blood, when you remove your finger, no blood will return into that vessel. This illustrates two things: the direction of the blood flow, as well as the fact that there are valves in the veins that prevent backflow. Another means is the thoracic or respiratory pump. When we inhale, the thoracic cavity expands and the thoracic pressure is going to decrease. The abdominal pressure is going to be higher, and thus blood is forced upwards. It doesn't get forced back because of the venous valves. When we inhale, the pressure in the thoracic cavity is about 2 millimeters of mercury, and when you exhale, it's about 6. So blood flows much faster when we inhale through the thoracic cavity because of the drop in pressure. There's less resistance on the vessels and blood can move up. There's also cardiac suction. This occurs during ventricular systole. The tendinous cords have pulled the AV valve cusps downwards and expand the atrial space. This creates a slight suction that draws back into the atria from the vena cava after each pump of the heart. So knowing what we know now about the skeletal muscle pump, it's understandable that physical activity would have an impact on venous return. First of all, we know exercise is going to increase venous return. It does this in several ways. First of all, the heart will beat faster and harder, and thus we increase the cardiac output as well as the blood pressure, and we're returning more blood to the heart. We know that the vessels of the skeletal muscle, the lungs and the heart, dilate with the increased flow, and so we have less resistance and thus more flow. An increased respiratory rate will increase the action of the thoracic pump, pushing blood back towards the heart more quickly. And then the skeletal muscle pump, with increased activity in the legs and arms, we're going to be returning blood much more quickly to the heart up through each of those valves. Now, in the case of inactivity, we'll see venous pooling. That's like the example of sitting in the airplane and not moving. We have no skeletal muscle pump. We don't see that the thoracic pump is working because we're not breathing very hard, and our heart's not beating very fast. So venous pressure is not enough to force blood back upwards all on its own. So when we stand for a long time, our cardiac output might be low enough to cause dizziness. Maybe you've experienced that, where you're standing, especially with your knees locked, for a prolonged period of time. Basically, the blood pools down in our feet and it's not getting back to our head. Now, if our brain isn't getting enough blood supply, then it's going to put a quick correction to that venous pooling by making you lie down quite quickly. We can prevent venous pooling by tensing the leg muscles. So even though we're not physically moving, just making contractions in those muscles to continue acting to pump blood back towards the heart. And pilots that fly very fast jets are going to wear pressure suits to prevent this venous pooling, because you could imagine venous pooling and drawing blood away from the head for a pilot could be a bad situation. Now, if we don't have enough venous return, we can end up in a situation of circulatory shock. That's any state in which cardiac output's not sufficient to meet the body's metabolic needs. It could be because of cardiac output or from venous return. In cardiogenic shock, it's because of inadequate pumping of the heart. Usually that's because of myocardial infarction. Or if we have low venous return, the cardiac output is too low because too little blood is actually returning to the heart. There's three principal forms of low venous return circulatory shock. There's hypovolemic shock. This is because of a low volume, hypovolemic. It's the most common. We have either trauma or burns or severe dehydration can lead the blood volume to be very low, and thus the heart doesn't get enough volume returned, and thus there's not enough cardiac output. Some individuals might experience circulatory shock because of obstructed venous return. That would be like a tumor or an aneurysm compressing the brain, so there's an obstruction physically in the way of blood getting back to the heart. And the third kind is venous pooling or vascular shock. Vascular shock is the type of shock that comes from long periods of standing or sitting, or because of widespread vasodilation for some reason. When we lose the vasomotor turn because of this dilation, it's called neurogenic shock. This can often result from emotional shock or brainstem injury. You know the idea when people hear some crazy news and they pass out. Septic shock is a result of bacterial toxins causing vasodilation and increased capillary permeability, so we lose fluid to the tissues. And anaphylactic shock is where we have severe immune reactions to an antigen, such as a bee sting or an ant bite, and that causes a big histamine release. And that big histamine release causes a generalized vasodilation and increases the capillary permeability, so people again are losing fluids. There are two responses that can happen in circulatory shock. First is compensated shock, where the body compensates, and then decompensated shock is when the body is unable to adapt to this situation and bring it back into balance. In compensated shock, there are several homeostatic mechanisms that pull about this spontaneous recovery. In the case of compensated shock, the decreased blood pressure is actually able to stimulate the baroreflex and the release of angiotensin II, and both of those will counteract shock by stimulating vasoconstriction. When we constrict the vessels, we get enough venous return, enough cardiac output, and everything's back to normal. If the person faints or falls down into the horizontal position, gravity is going to quickly restore blood flow to the brain. And we elevate people's feet during shock because that aids in returning blood flow to the brain much more rapidly. Now, in the case of decompensated shock, the compensating mechanisms are inadequate. And what happens then is we'll see life-threatening positive feedback loops happening. The poor cardiac output is going to result in ischemia of the heart and possibly heart attack. That further weakens the heart and reduces output. So that's a positive feedback loop. The slow circulation can become so slow that it leads to intravascular coagulation. So vessels become congested with clotted blood because it's moving so slowly. And of course, that causes the venous return to grow even worse. If the brain isn't getting enough fuel, then we'll see ischemia or acidosis of the brain with waste products not being moved away. This depresses the vasomotor and cardiac centers, which can cause further loss of vasomotor tone, further dilation, and a further drop in blood pressure and cardiac output. In the case of decompensated shock, the damage to the cardiac and brain tissues can be much too great to survive. So it's very important to get immediate help when someone's body is not compensating for the shock. So pause here for a moment, pull out a piece of paper, and write down all the means of venous return that you can remember. Again, take a risk, get it wrong, miss some things, and then go back and check in your notes and see what you have missing. Fill in the spaces. Certain circulatory pathways have special physiological properties adapted to the functions of their specific organs. We've already covered the coronary circulation, and later in the semester we'll cover the fetal and placental circulation. But now let's take a closer look at circulation to the brain, skeletal muscle, and lungs. The total blood flow to the brain is going to fluctuate less than that of any other organ. It stays fairly consistently at 700 milliliters per minute. Any seconds of deprivation can cause loss of consciousness. Minutes of deprivation can cause irreversible brain damage. The other thing is that blood flow in the brain can be shifted from one active region to another to take care of the metabolic needs within a matter of seconds. The brain will regulate its own flow to match changes in the blood pressure and its chemistry. There are cerebral arteries which will dilate as the systemic blood pressure drops and constrict as the blood pressure rises. The brain, as we learned, detects its own chemistry. The main stimulus is going to be pH because both carbon dioxide and pH itself are going to impact these receptors. Carbon dioxide, when it's transported in the blood, mixes with water and forms hydrogen ions in the end, and these hydrogen ions will impact the pH. The more hydrogen ions in the solution, the more acidic it is, or the lower the pH. Thus, the condition of hypercapnia, when CO2 levels are high, we're going to see a decrease in pH. This decrease in pH triggers vasodilation so that the brain can get a better blood supply. In hypocapnia, when there's very little carbon dioxide, the pH is going to raise, that is, become less acidic, and this stimulates vasoconstriction. Hypocapnia only really occurs with hypoventilation. Freedivers use this technique often, where they hyperventilate to blow off CO2, and that gives them a little bit more time in their long, deep dives. If it's overdone, though, it could cause ischemia and dizziness and, in some people, syncope, as in passing out. So in the event that the brain is not getting enough blood, we might see transient ischemic attacks. They're characterized by temporary dizziness or loss of vision or other senses. We might see weakness or paralysis, headache, or aphasia. They can last from a few moments to a few hours, and they're often an early warning sign of an impending stroke. So if you have transient ischemic attacks, or you know someone having them, it's very important to get immediate medical care. In the case of a stroke, which is otherwise known as a CVA or cerebrovascular accident, there will be sudden death of brain tissue that's caused by this ischemia. This can result from atherosclerosis, thrombosis, or ruptured aneurysms, anything that's interrupting blood supply to a particular region of the brain. The effects can range from fairly unnoticeable to absolutely fatal. And symptoms include basically any functions of the brain. We might see blindness, paralysis, loss of sensation, or loss of speech. Are the most common ones. Recovery for stroke really depends on the surrounding neurons and the collateral circulation. There's a concept of plasticity in the brain, which is that if one area of the brain tissue dies, then another region's neurons will take over that function. This is a pretty predominant area of neural research right now. So strokes would be a great topic to cover for your end of semester presentation. Skeletal muscle differs from the brain a lot, and it has a very high and variable flow of blood, which depends on the state of exertion. At rest, the arterioles are constricted. Most of the capillary beds are shut down, and the total flow of blood is only about 1 liter per minute. However, during exercise, the arterioles dilate in response to epinephrine and sympathetic nerves, and we'll see the precapillary sphincters dilate due to muscle metabolites like lactic acid and carbon dioxide, and blood flow can increase about 20-fold. Of course, muscular contraction will impede the flow. Isometric contractions, thus, will cause fatigue much faster than intermittent isotonic contractions. The isotonic, we've got the same tension but changing length. That would be an example of bicep curls. And that's going to allow the skeletal muscle pump to act. However, an isometric contraction, where it's just a sustained contraction with no movement, is going to block the vessels. Thus, it's impeding the delivery of nutrients, and it will fatigue much faster. After the time of birth, the pulmonary circuit's the only route in which the arterial blood contains less oxygen than the venous blood. And that's because the pulmonary arteries are carrying deoxygenated blood to the lungs to get replenished, and then returning oxygenated blood through the pulmonary veins. So basically, it's the only time where the red and blue blood is switched in the circuits. The pulmonary arteries have very thin dispensable tissue, and thus they have a much lower blood pressure. So pulmonary pressure is about 25/10 millimeters of mercury. This allows for slower delivery of blood to the lungs and more time for gas exchange. We also see that oncotic pressure is going to override hydrostatic pressure, and this prevents fluid from accumulating in the alveolar walls and the lumens of the lungs. In the event of hypoxia, the pulmonary arteries actually constrict, which is sort of an opposite effect. So it cuts off the diseased or damaged area so that it doesn't get any blood supply. It redirects the blood to better ventilated regions of the lungs so it can pick up more oxygen. This is kind of a neat adaptation. So that brings us to the end of our regular lecture sections for this chapter. Next, we'll move on to look at the actual vessels of the circulatory system, beginning with the pulmonary circuit, then moving into the systemic vessels in the axial region, and then the appendicular region. See you soon.